I am Jason Flood, Senior Director of Strategy and Value-Based Care Analytics for Boston Medical Center Health System. It is my pleasure to moderate this panel today on dual eligibles. But first, I'd like to ground us in some data. There are about 12 million dual eligibles nationally. They represent about 19% of Medicare enrollees and 14% of Medicaid enrollees. However, they account for 34% and 30% of Medicare and Medicaid spending, respectively. This is driven by a combination of medical and social risk factors, and a population that's very complex. And we see this at Boston Medical Center through our Thrive screener for social determinants of health at every visit. Care for this population also represents a health equity issue. 46% identify as Black, Hispanic, or other people of color. And personally, my motivation for engagement in this work is driven by my parents and grandparents, who are all people of color and have faced significant financial distress in their lives. So I'm hoping we can all leave today with some actionable policy recommendations for really driving sustainable future of this population and care. So I'm really excited to turn to my panelists now. And I'll start with Dr. Vicky Fung. Can you tell us a bit more about the dual eligible population and why they are important?
Sure. Can everybody hear me? Okay. I think I accidentally turned off the microphone. Well, first of all, I wanted to just thank Marta and Colleen and the organizers for inviting me. I feel very humbled to be part of this panel and to be speaking to this room because I spent a lot of time researching dual eligibles, but I know you all are on the ground delivering all the services and care that they need. And so I just come to this very humbly, I'll be offering a lot of kind of what we know about data and duals from a research perspective, but I really welcome your thoughts and ideas, find me afterwards. So in any case, dual eligibles, I think Jason provided a really important overview. So who are they? I mean, these are individuals who qualify for Medicare on the basis of age or disability, about 2/3 via age and about 1/3 via disability under age 65. In Massachusetts, that is, it's closer to half who qualify under age 65. They are an extremely clinically and socially vulnerable population. They have high levels of clinical need. About a quarter have 5 or more chronic conditions. About half have at least one functional limitation with an activity of daily living. Many people have also co-occurring behavioral health conditions. And they also are very socially vulnerable. As Jason mentioned, a large portion are from racial and ethnic minority communities. About half face food insecurity, and numerous more face other adverse social determinants of health. So this is a really high-need population. And why are they important? I mean, I think when we think about the goals of our healthcare system, all roads really lead through duals, right? When we're thinking about equity, we have to address the care for duals. When we think about efficiency and spending and sort of increasing the amount of high-value care and reducing the amount of low-value care in the system, duals, like we really have to focus on duals. And when we think about sort of innovative payment models and how do we move away from sort of traditional fee-for-service models towards innovative payment models that address the comprehensive needs of beneficiaries, including their social needs, we have to think about duals. So I'll stop there.
Thank you so much. I'll ask you a follow-up question. Can you tell us a bit more about why dual eligible coverage is so complex and why we don't have meaningful data to assess the efficacy of these models?
Yeah, so why is it so complex? I mean, essentially, dual eligibles have to navigate 2 completely different insurance systems that were not built or designed to work with each other. So, what we have is the system we built and is kind of designed that way. So Medicare is, this is all basic information, but Medicare is the primary payer for outpatient, inpatient, and prescription drug services. For full benefit dual eligibles, who comprise about 70% of the population, Medicaid covers long-term services and supports and some other benefits like vision, dental, things that aren't covered by Medicare. beneficiaries have a choice of sort of the delivery models through which they'll receive care, including through fee-for-service or managed care. And so that occurs in both settings, on the Medicaid side and on the Medicare side. Just within the Medicare side, you can get your Medicare benefits through traditional fee-for-service Medicare. You could choose a private Medicare Advantage plan. And that managed care plan could be a dual eligible special needs plan that's tailored to the needs of duals, or it could be a regular MA plan. And then amongst the D-SNP plans, in many parts of the country, not necessarily Massachusetts, you have a choice of an integrated versus a non-integrated D-SNP. So first off, there's just a lot of different options for receiving your benefits within both programs. That's very complex. And they're very fragmented. I mean, the predominant model that people are in are non-integrated models. And so within a non-integrated models, beneficiaries have to navigate 2 completely separate enrollment processes, 2 separate provider networks, 2 separate sets of benefits, coverage, and rules, and 2 separate grievance and appeals processes. So this can lead to just obviously a lot of burden, administrative burden, confusion, delays in receiving needed care, and unmet need. We're going to talk a lot, I think, about the data going forward, so I don't want to take up too much more time, except to say that the data is also extremely fragmented and siloed, and we have a lot of players. We have the fee-for-service, Medicaid, and Medicare claims. Those are separate. We have 50 states, plus 50 or more Medicaid programs that are very different. We have many different managed care plans that are in this space that also collect data differently. And then obviously we have the role of the social services organizations. So figuring out how to integrate all this data is a real challenge.
Thank you. Moving now to John. United Healthcare's community plan plays a crucial role in coordinating home and community-based supports, services, and long-term services and supports for members of your SCO, senior care options, and One Care plans. Could you talk a bit more about these services for your dual-eligible members, and then a bit about the contractual and regulatory oversight and the impact that those have on individuals at both the federal and state level?
Yes, thank you. And first of all, thank you for having me here this afternoon. I'm honored to be here, Marta and your team. We appreciate all the collaboration that we already do. I'm sure there's more to do. But a little bit about the programs that we offer at United Healthcare Community Plan of Massachusetts. We offer 2 programs, the SCO, or Senior Care Options Program, that most of you are familiar with. And we also do the One Care program, which is a MMP or Medicare and Medicaid program that serves people who are 21 to 64 years old who qualify for both Medicare and Medicaid. So both of these are integrated care programs, and the integration includes everything in healthcare that you might think of. In the SCO program, we're offering your medical services, going to the doctor, going to the hospital, but we also have long-term services and supports as well that we also cover. So your home and community-based services that are provided in your home, or if somebody needs the level of care that requires for them to be in a nursing home, then that's also provided in your SCO. Then we have added supplemental benefits that we add to these programs as well that make it easier for folks to coordinate their care and provide other benefits that otherwise would not be provided through Medicare or Medicaid. So you asked a little bit about regulatory. As Vicky mentioned, these programs obviously are designed to be 2 separate programs, Medicaid with regulations coming from the state, Medicare with regulations coming from the federal government, CMS. And because of that, oftentimes those 2 things have to come together. And so not only do we have regulations, CMS regulations we have to follow, we also have Medicaid, and then we have all the accreditation bodies that were mentioned by Dr. Rishi earlier. The NCQA and other accreditors that are also putting maybe not regulations, but standards that need to be followed. oftentimes this can be challenging, but the beauty of integrated care programs is that plans like mine do all that back work of making sure that we're creating programs that ensure that we're meeting all the regulations across the board. Does it cause confusion? Yes, it does. Do we have opportunities to straighten some of those out? I think Massachusetts, as you heard, is probably in the forefront. Having worked in another market where those two are not always aligned, we are actually a step ahead of most markets in the sense that Mass Health is working very closely with CMS to ensure that there's alignment in those services.
Thank you so much. Turning now to David Seltz. The Massachusetts Health Policy Commission focuses on monitoring healthcare spending in Massachusetts and provides data-driven policy recommendations regarding healthcare delivery and payment reform in Mass. Can you tell us a bit about the challenges of making meaningful policy recommendations for dual-eligible participants?
Great. Thank you, Jason. Good afternoon, everyone. It's really an honor to be here with my fellow panelists and to be part of this conversation today. This has been just a really wonderful day. I thought the last presentation was just so excellent, and I'm truly inspired by some of the comments that were made. I just want to also recognize my fellow colleagues here in state government and in the state legislature. Great to see you here. Before I get to your question, Jason, I do want to just spend maybe just a few minutes just talking about who the Health Policy Commission is. I think many of you may know us, but we just do want to take that opportunity since we're still, I guess, not a new state agency anymore, but many may not know about us. We're an agency that is part of a proud legacy of healthcare reform in Massachusetts. In 2006, Massachusetts became the first state in this country to say that every resident of the state should have access to health insurance and that everyone should have coverage. And that was like such a bold step forward that required compromise from so many different stakeholders, and it worked. And to this day, Massachusetts still has the lowest rate of uninsurance of any state in this country, and that law became the model for the Affordable Care Act, which led to tens of millions of Americans having access to affordable coverage. That is a huge success, and Massachusetts is rightfully proud of that. However, after we passed that law, we wrestled with the fact that having coverage doesn't mean access always. Having health insurance, if you can't access care, sometimes that means being functionally uninsured. And one of the biggest barriers to accessing care when you have coverage is the cost of care. And there was a graph shown earlier about the cost of care in the United States compared to all of the other countries. Well, if you looked at just the states in the United States, and you looked at all the different states, in 2010, Massachusetts had the highest per person costs of healthcare of any state in the United States. And so if you compare that with what we know about the United States versus every other country, in 2010, Massachusetts was the most expensive place on the planet for healthcare. How do we keep our promise to our residents about having coverage and being able to access care if we can't afford it? And so in 2012, policymakers came together and said, we need to chart a more sustainable path when it comes to affordability and being able to moderate the growth in healthcare costs. And I want to emphasize those words, moderate and growth. This isn't about cutting. This isn't about taking away. It's about putting our state on a more sustainable path. And to do that, the legislature created this brand new unique state agency, the Health Policy Commission. It would have as its sole focus to being able to look at the entire healthcare system and to be able to monitor healthcare spending, and not just healthcare spending, but all aspects of delivery across the entire system, to be able to then make policy recommendations to the legislature, to the marketplace, to help guide our system forward to be more affordable, more accessible, and more equitable. What's unique about the Health Policy Commission, I think, our mandate, and what's, I think, unique to this conversation, Jason, is that we look at all aspects of spending. Medicare, Medicaid, commercial spending, all of that together, and what people pay out of pocket. And I think that's important, and that was a real innovation at its time, because if we just looked at Medicaid spending, or if we just looked at commercial spending, what would inevitably happen? We'd be missing the part of the picture, right? We'd be looking at commercial spending, and what would happen? Something would be going over here on Medicaid. If we just looked at Medicaid, we'd say, let's hold down Medicaid. Something would happen somewhere else. You have to look at the holistic picture. And I think that's really important when we think about the dual eligible population. Let's look at this as a holistic picture. Let's not look at this as two separate programs. Let's look at this as holistic system and holistic people with holistic needs. And so I think that is a unique viewpoint that the Health Policy Commission brings to looking at our entire system. How do we actually go about trying to influence and change this massive healthcare system in Massachusetts? By the way, the biggest employer in Massachusetts, $60 billion a year. We work by trying to partner with organizations and providers to test innovative new ways of delivering care. We work to convene people. We're a market monitor. We evaluate mergers and acquisitions and the ever-increasing drive to consolidation. And we also do a lot of research and data. And unfortunately, that data, as has already been talked about with the dual eligible population, is so fragmented. And so while you would think that we would be best positioned to have that holistic view, to be able to identify those opportunities for this particular population, I'm telling you, it's so hard. To be able to match all of those data points across these different programs, and then being able to think about the fact that we're only looking now at the medical system. And we know that the needs for this population go far beyond the medical system. So we need to do better. We can't wait for the data to be perfect either, because the needs are great, the challenges are great, but the opportunities are tremendous.
Wow, yeah, that's what a great note. I'd love to open it up to the three of you. There's been significant growth in enrollments in integrated plans. So I'd love to hear, why is integrated care critical for dual eligible beneficiaries? And if you could discuss some integrated care models and explain how they might be improved and what policy changes might need to take place.
Yeah, I'll go first. And I mean, one integrated good example, SCO, or One Care, which are programs that are mandated here in Massachusetts for people who are older than 65 and are duly eligible. Two great examples of integrated care programs. Why is integration so important? I think to Vicky's point, some of the challenges that we have when people are being, or people's healthcare coverage is being covered by two different entities is that one entity doesn't get to see what the other entity is doing. So for example, if somebody was both eligible for Medicaid and for Medicare, their hospital bills would be paid under Medicare, or their physician bills would be paid under Medicare. But if they needed anything that was paid by Medicaid, it would be paid by Mass Health, for example, in this state. As a health plan, if you're managing somebody's care and you want to be comprehensive and see that person as a whole, you want to be able to see where they're getting all their care. So today in the SCOPE program, we cover both sides of that equation, and we also cover their behavioral health and dental and other services that they get through Medicaid, so the LTSS services. Because of that, we can actually do two things. One is the data comes into us through claims, so we know where people have been, where they've been seen, who they've received care from, and we can better manage their health. And then we can also provide a care coordination service, which is really fundamental to the work that you do in integration. We have nurses, social workers, CHWs that then work to coordinate the care of that person under one plan, under one network of providers who are all linked through the health plan. So that's one of the bigger benefits. And then, of course, we can't do any of that without the ASAPs. So for the HCBS services in particular, it is the ASAPs, it's you that are doing the work on our behalf to build the networks of all the providers, the mom and pops that do all the home delivery, food delivery, that do the home care, folks that are building ramps or modifying people's homes. We rely on the ASAPs to help us coordinate that care. And when we do that, we now have a much better and much fuller picture of the person's health care than just what happens at the doctor's office or in the hospital.
Yeah, I mean, it's hard to follow that, but I'd say that so these integrated models largely, point to things like SCO and OneCare. So these sort of integrated managed care plans that are financially at risk for the spending on both the Medicare and the Medicaid side, as well as PACE programs. And so I think the latest data that I saw, I mean, there's been a lot of growth in integrated models, to be sure, but the predominant delivery model for duals remains a non-integrated option, and a lot of folks still in sort of fee-for-service, non-integrated plans. There have been a lot of, there's been some strengthening on the CMS side around rules for DSNPs to become more integrated, and so I think there's a lot of policy enthusiasm around strengthening integration requirements and using this platform of DSNPs, which already has a really large enrollment, millions of enrollees, as a way to integrate care and to align incentives. Of course, care coordination is huge. And also just aligning the incentives. I think under the old models, there are a lot of examples of sort of shifting of costs between the state Medicaid programs and the federal Medicare program in ways that are not beneficial to beneficiaries. So I think ideally we align the incentives and we align the coordination and should benefit ideally everybody.
Yeah, I just to add on to the point, I think the aligning incentives is really good, but also just to bring it back to like the patient perspective as well, and for a patient to feel that their care is being integrated and that they're not having to talk to 5 different care managers and 7 different care coordinators and 3 different pharmacy management coordinators. Like, they're one person, and their care and their needs should feel that they're being integrated and coordinated, not separated by Medicare and Medicaid rules and regulations by government agencies they don't understand. So how can we put the patient at the center of this?
That's a great answers, thank you. Vicki, I'd love to come back to you. Measuring the quality of care and healthcare equity among dual eligible individuals requires pulling data across various sources, a challenge I think you and I know well. Can you provide an overview of some of the sources that exist and some of the challenges in accessing and synthesizing these data?
Yeah, so I spend a lot of time working with data, so we're in my comfort zone here. I'll talk about it from the researcher perspective, because I think that data access also varies a lot depending on where you sit in the system. So thinking about kind of how we evaluate policies, I use a lot of CMS data. So I'm requesting Medicare and Medicaid administrative data. So this can include enrollment data, as well as claims data on the fee-for-service side and managed care encounter data. These tend to be, even though they're all managed by CMS, they're also separate data files. So it's really intensive to be able to link them. There's not really a standing resource that integrates this information for dual eligibles. You have to be able to work with all these different types of data to be able to have a comprehensive picture of just basic care utilization and enrollment for duals. And for some of the data sets, the data quality is still evolving. So there's a huge initiative to improve the quality of Medicaid data through what's called the TMSIS data or the TAF. Most states are now using, or all states are using this format now from 2016 onward. But there are still a lot of gaps and holes in sort of the quality of various data elements, and it varies a lot by state, it varies a lot by payer. And so that can really kind of limit sort of the usability of some of the data. You know, I was just thinking about one of the slides that Dr. Machanda had on the board around like sort of how 150 research studies, only 2 like centered equity. Some of that comes back to data. I was just looking at the most recent data that's available through the TMSIS 2022. There are 15 states that still have race ethnicity data that is of high concern in terms of data quality or unusable. And when you try to link together multiple years of that and combine it with other data elements, you start to lose the ability to look at its really comprehensive picture. So, okay, that's one set of data is administrative data. There's also, so administrative data gives you good information on sort of when people are touching the healthcare system, what they receive, when they see the doctor, when they go to the hospital. In terms of beneficiary experiences or patient experiences, that's harder to measure and collect. There are some survey data. There's things like the Medicare Current Beneficiaries Survey, there's NHATS, there's a lot of sort of national survey data. Some of this is linkable with administrative data, some of it is not. You're obviously getting down to smaller samples when you talk about survey data. And then there's assessment data. And generally what's available to research on the assessment side is the NDS, so nursing home assessment data, and Medicare covered home health assessment data. But what we're really lacking is sort of HCBS-related assessment data that comprises most of the utilization around LTSS for the duals. And we really don't have, that's largely missing. So we have a lot of data, it doesn't all link together. The data quality is still an issue, as well as the timeliness. I would say we generally get data with about a 2 to 3 year lag, so it's difficult to kind of produce findings at the speed that decision and policymakers are looking for that data. So those are some of the challenges. I guess I'll just note one other thing is, the social services data is also like really difficult to come by. We have very little information on the social risk factors that beneficiaries face. We have very little information to determine sort of who's eligible for various services. And so I think, as we think through the rest of this panel about how do we overcome this, I think partnerships are going to be really key, and I look forward to kind of just thinking, brainstorming ways that we can kind of fill a lot of these data gaps.
Thank you so much. John, on the theme of alignment, can you talk about the need for contractual alignment across the continuum of care and a value-based care model for dual eligible beneficiaries? And can you highlight the role community-based organizations can play? What should a risk contract or data sharing look like in an ideal state?
Yeah, so this, and it was so good to hear the doctor speak this morning, because I think what he spoke to is what is the biggest challenge that we have today. I've always believed, having worked as a home health worker, that the best information about anyone's health care is known by the people who are taking care of that person. And oftentimes, if you look at the way we are structured in healthcare today, we have a lot of data about what the doctors are doing in the hospitals, what the doctors are doing at the clinics, but we don't have any data about what the caregivers are doing at the home. And oftentimes, it is that data that is the most predictive about what the outcomes of that person are going to be. So if we're going to go upstream, as the doctor said this morning, I think I was the one that was swimming upstream. If we're going to go upstream, then we really have to start, with the information that's at the home when the person is getting care from their loved ones, or whether it's an agency that's providing supports for that person. I think collecting that data will give us the best information to tell when something is about to go wrong, so that we don't have the most expensive care that we end up having to provide at the ER, in the hospital, and then beyond that, right? Nursing homes and other places. So I think in terms of alignment, I think one of the things that we really need to do, and I think it was mentioned also earlier this morning, I should just say what he said, and that should answer the question. It was also mentioned this morning that we really have to have alignment about how we measure things or how we collect data, so that systematically we're all speaking the same language. And then it's easier for us then to use that data to determine where we need to put our resources. Some of the things that we're trying to do today with ASAP providers is to just start that idea of collecting data together, sharing that data, and then using that data to incentivize the behaviors that we want to see, whether at the ASAP level, whether it's at the home care level. We already do that a lot with physicians and physician practices in the ACO arrangements that we have. We do it in the hospitals. We provide incentives for doctors to manage care in certain ways that provide the best care at the lowest cost, right? Because we're all trying to bend that curve that we saw. But we're not doing enough of that at the home care level. And I think part of that is because, number one, the infrastructure for collecting that data is not there, or if it's there today, it's so different. Every organization is using their own system, and they're using their own standards for collecting data. So I think, if we're going to get to, again, mentioned this morning, if we're going to get to level 5 of a relationship, there are certain things that we're going to need to do up front. One of those is create infrastructure that allows us to speak the same language, collect the same data, and then share that data back and forth, so that we can start to really be able to figure out what are the outcomes that we're seeking at the member level, right? Because that's where it matters. And how do we measure those outcomes in the same way across the board, so that we can now be very focused about how we go about doing that.
Just to add to that, I completely agree, and I think the alignment of data, the collection of the data, it is essential. But I wonder if there is a limit to that at some point. And I wonder if there is a place and a time where we start to over-medicalize services that are truly not right for that type of thing, and start to create billing codes for every single thing that a community provider is doing. And I worry about that. I think about some of the, I think about some of a grant program that we did with an organization that was working on food insecurity, that was working on upstream food insecurity. And it was working about changing food policy in a community. And part of that work was working with community organizations, it was working with a healthcare organization, partnering with community organizations to create and change food policy within that community. And part of that was about empowering youth to be advocates within their community, to advocate for change within their local town and city council. I don't know what the data you collect that measures empowerment, but that's powerful. Mm-hmm. So we got to be able to think about both.
Yeah, that's a really powerful sentiment there. David, I was hoping you could talk a little bit about the healthcare cost trends hearing that happened recently. As we sort of work to reflect on trends and collaboratively towards a more equitable healthcare system. You highlighted how health disparities across income, racial, and ethnic groups still persist. Can you discuss how these health disparities widen for dual-eligible populations, and what solutions are needed to ensure we continue to address these as our population ages?
Yeah, thank you, Jason. And I'll just say, we're, as I mentioned before, our agency is focused on affordability, but our mission statement is better care, better health at a lower cost for all residents of the Commonwealth. And we have embedded health equity as part of our mission and values. We don't think that we can achieve our mission unless we achieve health equity. And so, as Dr. Manchanda said, we have to center health equity in all of our work. Our healthcare cost trends hearings, if you don't know, it's an annual opportunity, again, pretty unique to Massachusetts, where we're able to call as witnesses the CEOs of our major health systems and health plans to testify under oath before the board of the Health Policy Commission in public to answer questions about the progress we're making as a system. I guess I would say, and sum it up, to use Dr. Manchanda's words, to confront some of the peril that we have and to identify opportunities. And so, we've really had a greater focus on confronting the peril of our longstanding health disparities in our system, especially in recent years. And he challenged us to think about the cost of inaction when it comes to inequities. Well, there has been a recent study that did that very same exact thing, the Health Equity Compact here in Massachusetts, an incredible group of leaders commissioned to study, $6 billion a year, the cost of inaction for not addressing health inequities in Massachusetts, $6 billion a year in avoidable healthcare costs and lost productivity. I'm going to take your question in a slightly different direction, but I promise you I'll circle back at the end to answer your question. We're gearing up for our cost trends hearings in about a month from now. We're going to be focusing on the ripple effects of the bankruptcy and dissolution of Steward Healthcare. I will share with this group, this has been the most discouraging chapter of my 20-year career in health policy. Seeing this system fail and the devastating toll that it's taken on communities, on healthcare workers, on patients, it's just been, it's challenged my optimism in many ways. I see this this failure as something that we need to really learn the right lessons from. And if the takeaway is that this was the act of one alleged criminal and that we should just all move on, we have learned the wrong lesson. Because there are deep-seated dysfunctions in our healthcare system that created the environment for the rapacious activities of this particular private equity company and this particular alleged criminal. We have long-standing disparities in the way we finance healthcare, disparities that do not finance care for low-income individuals in the same way that we finance for others. The long-standing inequities in the way that we supply, the supply and distribution of our healthcare services and how those healthcare services are supported and maintained to be viable. And when I look at the closure of some of those services, I see a lack of, or I should say, I see an opportunity in the future for more proactive planning about how we can better align our supply of services to meet the needs of patients, rather than being reactive to market forces, which often do not have the needs of the public or patients in mind. And so when I think about the future of what our Commonwealth is going to need, an aging Commonwealth where there are going to be more and more dual eligible patients, we need to be thinking of the future, and we need to be planning for that future. And I don't think that we can count on the market forces to be delivering a system that's going to be meeting the needs of these dual eligible populations. So how do we create that system, and how do we create that plan for the future? Let's learn the right lessons from Steward's failures.
We need the right systems of accountability, right, as well. I'd like to take us in a slightly different direction and talk a little bit about LTSS services. So John, can you tell us more about LTSS service delivery and and some of the challenges therein, including direct workforce shortages, duplication of intakes, siloed providers, things of that nature. And how can we innovate to increase efficiencies in this delivery system to best meet the needs of our aging population?
Yeah, so I think Vicky mentioned LTSS services are some of the most costly services that we provide today for the dual population. So you think about LTSS services as being the home and community-based services, so things that folks need to be able to stay at home and stay independent in their home. It also includes nursing home care, but I think for this audience, I think we're really talking about the work that the ASAPs do on our behalf. So one of the things that we work with the ASAPs on is building a network of providers that can help us provide care to every member that we have across the state. And so for a health plan like ours, that would be such an incredible amount of work to do and to manage just at the health plan level. So the support that we get from the ASAPs to find these providers, manage those providers, and make sure that when we have members who need those services, the ASAPs are helping us to assess the services that are needed, and then ensuring that those people get the service they need as quickly as they can is instrumental. The challenges that we're seeing now, and I think most people in this room would agree, is post-COVID, we've seen a lot of people leave this industry. Folks that were doing this work have decided to go work elsewhere for various reasons. And we're not seeing as many people come back and want to work and do this level of work. And I think some of the reasons why people are making those decisions were mentioned again earlier this morning. And so how do we go about, and so the other problem that we have is we have such a diverse population who need these services, particularly here in Massachusetts, and finding the right worker who matches the person who needs the service. So you think about language barriers. Those are also some things that have become challenging. So there's a lot that needs to be done in terms of getting more people interested or attracting more people to work in this industry, but also attracting people who match the folks that we are trying to take care of. I think everyone knows that in order to provide equitable care, one of the things that's primary in that discussion is getting care from somebody who looks like you, talks like you, has similar cultural background as you have. And I think that's going to be a primary issue that we're going to need to address going forward. The services are different for different people, depending on your need, but we also have some challenges depending on where people are getting these services. If you're getting them through fee-for-service versus the services that you get through a SCO or One Care program, or the Frail Elderly Waiver membership, right, who are getting additional services there. So there's so much differentiation between what's available in HCBS, and because there's no real alignment as to how those services are provided, there's also inequity in how those services are provided, and access becomes challenging for certain neighborhoods or certain areas. Rural areas, for example, have a hard time getting HCBS services. But then we also know there's some communities where folks would just rather not go into those communities to provide services, and that also creates disparity. So there's work to be done, and I was encouraged by the discussion this morning, because I think one of the ways to solve the problem that we have in terms of the financial piece, right? Like how do we fund the work that we need to fund, and how do we pay people appropriately, is really to do what Dr. Manchanda was talking about, right? Can we invest more in the infrastructure that's needed, and not in a, like you said, not in a health medical necessity way, but more like a community necessity way? And one way to do that is really to change the paradigm on how we pay for services, and pay, if we can get to that level 5 that Dr. Manchanda was speaking about, and we can pay, capitation in this space rather than in the doctor's office or at the hospital, I think we start to get to a place where you can now start to afford, the workforce that you need to be able to provide the appropriate care that is diverse enough to meet the needs of the population and allows people to stay more and more independent at home, which I think, I often ask this question. I'm going to ask it here before I stop. How many of us are looking forward to their first day at the nursing home? Right? That's usually the answer. So most of us want to stay independent. And so the only way we're all going to be independent and avoid the nursing home is to make sure that we build the workforce for HCBS, because we're all going to need it.
Yeah. So we've heard a lot about different policy options. I kind of want to open it back up to the three of you to talk about this challenge of integration that I think we've addressed in various forms for this population. To inform sort of equity-oriented policy, we have to invest in data infrastructure, interoperability, access to services. What should the future look like, thinking ahead, to ensure that we're collecting accurate, robust data that actually informs outcomes for our dual-eligible beneficiaries? And how can Medicare and Medicaid data be integrated to improve healthcare quality?
It's a great question. I was thinking about the story that Marta told earlier about Sam, and I was thinking about what, as a researcher, I would know about Sam, and it was almost nothing that was pertinent to his story. Would I be able to identify his spouse and that his spouse recently died in the data? No. Would I know anything about his housing arrangement, his social risk factors? We certainly wouldn't know about the eviction notice. We wouldn't know anything about sort of really what he would need to be able to function independently at home. And I think there's this real tension, because I hear what you're saying, David, about what is too much, right? The data is sort of overwhelming, and sort of the data burden can be a lot. But a lot of the data is already being collected, right? It's just all in different spots, and it uses different codes. And how do we just come up with at least some sort of unified or centralized way to be able to collect data that we think really matters? Not just around Sam's risk factors, but also his outcomes. When we're talking about outcomes, we're looking at things like hospitalizations and mortality. That's not really what we want to measure on this population. How do we capture meaningful data around quality of life or independence or having your care needs met or your depression or anxiety and all of those types of things? It's a real challenge, but I think that there is a lot of existing data, and I've had a lot of frustration as a researcher just trying to think about, even within sort of more narrow settings, not nationally, not across 50 states, but within a single healthcare setting or a single program, just the data live in all sorts of different silos, and it's very difficult to bring it together. It's very resource intensive. And, I think that the need to have some cross-sector collaboration in terms of thinking about what is the right way to collect data, have sort of bidirectional exchange, have interoperable systems that can work across different settings is going to be really critical, and we need upfront investment in that. We can't do it on the fly as we're developing the programs. It just doesn't work. We need to have that investment up front, and there need to be dollars that accompany these initiatives or programs or policies that seek to address social determinants to make sure that the infrastructure is sound to be able to evaluate it.
Thank you.
Coming from the cost containment agency, I agree in investment in this case. I do think, and this is part of, what we look at sometimes is that we need to invest our dollars wisely, and there are areas in healthcare where we need to put more money into it. And this is one of those areas. This is an area of investment, and I think we need to do it soon because I worry that some of these systems are going to create their own proprietary systems, and they'll have their own little closed sandboxes. Or Epic will say, okay, well, we'll create our own little module, and if you want to access this, well, here's going to be the monthly charge. These are important data for public use, for researchers, for government, to help improve programs that rely on government funding, for providers that are working with patients. These are not for private use and profit. And so let's have that common good. Let's have that public interest in mind as we do it. As government, as the only government official on this panel, I am cautious about the administrative burden part of it. Often, we can always say, let's add another data field, let's add another data requirement, let's add another report. When I think about, and literally our agency can do that. I think it's important to involve when we're thinking about what that is, who are the data collectors, who are the data users, and who are the people behind the data in that, and not just have it be a top-down approach. So a few thoughts to add on.
Yeah, and ditto to both those points. And the only thing I would add is I'm fortunate enough to participate and be able to sit on the health policy, health equity compact, which is a group of BIPOC leaders in healthcare, and it's increasingly, I guess, satisfying to know that some of the conversations that we're having in that setting are the same conversations that we're having here as well. So the only thing I would add is that there's a lot that we probably also need to do around policy and alignment of policy so that every department that touches the populations that we're serving is thinking about equity. So the centering of equity that was mentioned this morning again becomes critical, right? So that as people develop priorities, whether it's in housing, whether it's the folks that are managing, policing in these neighborhoods, folks who are doing transportation work, all these departments across government, across institutions, including private organizations like mine, if we all center around equity and we have policy that incentivizes all of us to think about this in the same way, then I think it's easier to get to the systems that we're talking to as well. So that policy alignment is going to be critical as well.
Thank you so much. Yes, that's very well said. Well, I'm being informed that our time is up. Thank you so much to the panelists for incredible